Okay. Would anyone like one more joke? Okay. You got the crickets ready? Just in case? Okay. So I was reading a book on anti-gravity the other day. It was impossible to put down. You're welcome. Here's a new one, actually bonus one for you. I was on Craigslist the other day and I saw this this radio that was on sale for $1. So I called the guy up and I was like, "What's up with this really cheap radio?" And he says, "Well, the volume's stuck at full blast." And I was like, "Oh, I can't turn that down." All right. So we're going to discuss immunizations today. So I don't know what your feelings are on immunizations. I'm strictly anti. So just kidding. No. I will generally take a positive approach with immunizations. We can discuss if you have any questions about that. Everyone has their own kind of predilections, feelings one way or the other. However, I'm going to be strongly in favor. In fact, I try to see if there's extra vaccines I could give to my children. It's almost like natural superpowers, like like, oh, now you're resistant to polio, and now you can't get typhoid fever. Like, it's kind of cool, right? So I think immunizations are neat. I certainly would like my children to get as many as possible. If anything else, it just encourages good behavior. Otherwise, they get more SHOTs. Anyway, so a little bit of history of vaccine. So it actually got started around the time that smallpox was kind of a big thing. We actually used to inoculate people with smallpox, and they would transfer pus from one patients who were infected to non-infected patients, and they actually found there was some conference of resistance by doing that. Who would like to participate in that sort of therapy nowadays? We have fecal transplants, which I think is the only other close thing in terms of current medical modalities that is quite as gross as that. However, we were starting to also see that patients or people, milkmaids, basically people who are working with cows who came into contact with cowpox did not get smallpox. So there's some degree of resistance that was developed there. And so actually, the word vaccine comes from the term vaxa, which comes from cow. It basically means cow in Latin. It's kind of interesting, I thought. Anyway, from there, we've had things like Pasteur developing rabies vaccines, which I know you guys have at least heard about rabies vaccine from Professor Quinones, so we can talk about that briefly later on. And then, things like, oral polio vaccine. Since we've had a pretty steady number of vaccines that have been produced, and so there's many that we can actually protect people from with these vaccines. So things like obviously, hepatitis. You have different varieties of hepatitis can be prevented. We have things like polio, obviously, MMRs, smallpox, shingles, all sorts of things. So I'm not going to go through every single one of these. I'll talk about a few of them that I think are of note, or you may run into some more use of, especially like in sort of an emergency room, sort of urgent care sort of setting. So we'll talk about those briefly, and talk about kind of the basics behind them. You've already covered like the pediatric kind of dosing schedule for immunizations with Dr. Nicholson. You haven't talked about that at all yet? Okay, we'll go over that briefly. We'll talk about that when we get to the dosing schedules a little bit later. But anyway, looking at actual vaccination of individuals and looking at actual occurrence of disease, we see that yes, in general, these prove to be pretty effective when you get the correct ones. Now, are vaccines 100% effective? No, they can be fallible. We'll actually find a good example with the flu vaccine this year, where this was basically the flu apocalypse. Like basically we didn't really get good coverage, and we'll talk about why that is a little bit later on. But anyway, we typically will see that when you vaccinate people, disease rates go down. When you stop vaccinating people, it comes back, right? So, what are some reasons people do not vaccinate? Anyone know? Oh, yeah, they're worried about autism. They're worried about autism causing, or vaccines causing autism. Anyone know primarily that was linked with? They think it was linked with? Really bad research, possibly. There was a mercury-based preservative called thimerosal. We'll talk about that a little bit later on. But that was what they were worried was causing autism in some of these individuals. So I'll mention that later. Any other reasons why people might not want to vaccinate? Adverse effects could be one, right? It could be religious reasons. Maybe they don't want to vaccinate from that reasons. It could be needle phobia, right? They don't want to get stuck with a needle. That could be one reason they don't want to do that. Lots of other things. And again, like the question is, like, if you individually did not get, say, vaccinated against polio, what are the chances of you getting polio nowadays? Pretty low, right? So what do you call that? herd immunity. So well, if I don't do it, it's not going to be a big deal because I'm not going to be around anyone that has the disease. I should be fine. That only works up to a point, obviously. Once enough people stop vaccinating, that's where things can start to come back around. You're starting to see more and more cases of things like measles starting to come up, mumps, things like that. These outbreaks that are occurring due to kind of lower vaccination rates that are occurring in those areas. So again, lots of different reasons. Some people want to rely on more kind of natural means of maybe preventing disease. People want to avoid all medications in general, but lots of reasons people may not want to vaccinate. And certainly I've seen plenty of people who will do kind of a delayed vaccination schedule where they may actually slow down the rate at which children especially are being exposed to vaccines. But there's lots of different ways to do it, lots of different ways to try to kind of customize it to your individual patient. But an example of, why should we immunize? In 1974, they had Japan had a very successful pertussis vaccination program. They were seeing that very few cases were being reported. However, by a couple of years later, only 10% of infants were actually getting vaccinated, and this one I saw a ton of new cases of pertussis showing up. And then when all of a sudden we started to vaccinate again, guess what the pertussis rates did? They went back down. It's like magic almost. So that's why you need to make sure that once you start these these kind of effective programs, you need to keep them going, because otherwise, once you start getting a little more lackadaisical about it, they can start to pop up again. So, lots of people die from vaccine preventable diseases, especially when you think about older, elderly patients. You think about things like pneumococcal disease, you think about the flu, like all these different things that could be potentially prevented. This is why it's important we have these recommendations. You try to follow them when possible for appropriate patients. We'll talk about some specific use cases, specific disease states that actually require different types of vaccination a little bit later on. But again, try to hold to these as best you can. In general, you're going to be preventing disease. It prevents is one of those cost-saving things you can do for a patient in kind of an epidemiologic standpoint, because if you can prevent disease, prevent hospitalization, it saves a ton of money overall. So anyway, so different types of immunity. So we have passive immunity. What's passive immunity? What baby? So a baby has passive immunity. Why? Yeah, they get some antibodies from mom, right, during transfer from the breast milk. Absolutely. What other types of passive immunity can we have? Absolutely. So I can give you antibodies to something, and that will give you a passive immunity, right? So again, the key point there is that the person themselves have not actually produced any immunity against the disease. As soon as the antibodies are gone, guess what? Person can get the disease again, right? They're no longer immune to that. So certainly we'll have immune sera, which can be transferred from human sources. So things like transplacental or breastfeeding can be one source, especially to be very protective for infants, because again, how good is an infant's immune system? Pretty crummy for the most part, right? You also have things like immune globulin. So immune globulin, we can actually have, we will harvest this from donated sources, and we can have immune globulin pool and administer to patients. We do this very frequently. We do this for a lot of like rheumatologic issues. We'll do this for a lot of patients like primary immunodeficiencies, things like that. So we use these quite frequently in the hospital. And there's things like antitoxin, which basically you could take serum that's kind of hyperimmune against a specific target and then inject that into a patient. So for instance, you could have like equine sources like horse antitoxins. What do you think I deal with this mostly from a tox standpoint? Yeah, snake bites are a big thing, right? So we have antitoxins that have available. We will immunize. Nowadays, we do more sheep sources. We do ovine sources. We'll hyperimmunize sheep. We'll spin down those antibodies. We'll isolate them, and then we can administer them and give them to patients to neutralize snake venom, right? So again, it's not it's the antitoxins, not against the snake itself, but it's against the actual venom that they're producing. So again, that's why I deal with it most frequently. How expensive do you think these medications are? Very expensive, right? So these tend to be much more expensive than your run-of-the-mill aspirin or ibuprofen or something like that. But then active immunity, this is where the person themselves is producing the immunity, where they're generating their own antibodies. Typically, what do you think about the durability of these responses versus like a passive immunity? Much longer, right? So again, typically this is where the person becomes vaccinated. They are immune to the disease, usually for a good long time. We'll talk about boosters and things like that a little bit later on. However, you usually get a delayed protection that occurs here. So again, if I were to give you something like an antitoxin, that will directly, that's already the active antibodies, that will directly neutralize whatever target it's focused on. However, with this active immunity, it takes time for it to kind of develop, usually a week or two before you really start to see good antibody production here. However, we can see that sometimes you have lifelong, resistance to certain diseases based on this. And certainly you can get this not just through vaccines, but the actual disease itself, right? So if I get, what's a good example of something you can develop immunity to? Hepatitis B. Okay, so maybe potentially you have developed that. I'm thinking more like chicken pox, things like that. A good example where once you get it once, you're kind of good to go, right? So, does anyone like when they got chicken pox as a kid, do they have to like get co-bedded with like their neighbors? You know, like that. That's what they used to do back in the day. So like, all right, you have chicken pox, to go hang out with these other neighbor kids, so that way you can give it to them, and then everyone's immune. But nowadays, we got vaccines for that. Anyway, so what are some predictors of response? How can we determine if a patient will have a good response to a vaccine or not? Certainly there's factors with the vaccine itself. So looking at the viability of the antigen. So we'll talk about different varieties of vaccines we can give, live attenuated versus inactivated. And sure, we've kind of alluded to these before, so we'll kind of go in more detail on these in a second. Look at the dose of the antigen. So in some cases, you may need to get the dose spread out over the course of several months in order to get kind of the full dose to get a full kind of immune response to that. It could depend on the actual type of vaccine itself. So in some cases, the target that we're trying to get antibodies against may be just a polysaccharide that we're administering. But in general, you're going to find polysaccharides are going to be kind of small molecules. They're not going to be as antigenic as you would see if you combine it with a protein. And so we'll look at some cases where we actually will use these conjugated vaccines to get a better response, especially like in infants, as we'll see in a second here. And then things like the route and site of administration. So for instance, a lot of vaccines are recommended to give them the deltoid. You tend to get better response. There's studies looking at antibody production after immunization via different routes, and they typically get better response out of things like the deltoid versus say like in the gluteal tissue. Typically, you're not going to be recommending a lot of gluteal administration for vaccines. So then host factors. So what do you think age would factor into this? How do you think that would affect how good of a response you would see to a vaccine? Who do you think would be poor responders, I should say? Really elderly, maybe have a poor immune system, maybe they're immunosuppressed. Who else? The very young, right? So we can see some issues with the very young where they may not be able to mount a good response, or we already mentioned that infants also tend to have what if they're breastfed? Good passive immunity, right? So you may actually find you have a hard time for them to actually generate their own antibody response because they already have circulating antibodies against certain things. And so we'll look at some examples of that. And when there's certain age cutoffs where before, if you give it too early, you actually don't get any good durable response. You have to give it after a certain age period. So I mentioned presence of maternal antibodies. Look at the interval between immunizations. Typically, you can't give it too soon to one another. Otherwise, you don't really get a good durable response. You have to kind of stimulate the immune system, give it time to kind of get back down to baseline, and stimulate it again to get an even better kind of antibody response to that. So we'll see that there's dosing guidelines based on time. And then also in coexisting disease. So what are some disease states that may diminish the ability to become immune to some of these diseases? HIV, more specifically, AIDS, right? So when you get more progressive HIV and you have a really depleted CD4 cell count, that's when you can have AIDS, and that's when you can have a very hard time mounting a good immune response against a vaccine. What else? Cancer, more specifically, treatment for the cancer, right? So again, if I have leukemia and I'm wiping out all the white blood cells, guess what? You can't really produce a whole lot of antibodies at that point. Anything else you can think of? We'll look at asplenia is a big one where they tend to be more susceptible to certain disease. So we'll see they have actual special dosing recommendations. So again, just little things to think about. So any kind of primary immunocompromisation, if they had some kind of primary immunodeficiency, they tend to be at big risk as well. So you can see that and who issues a lot of the guidelines for this stuff? Usually CDC, right? So CDC kind of taking a lot of the health departments kind of working in conjunction there, but the CDC recommends all these things, at least here for the U.S. So the different types of vaccines, we'll go into more detail on these in a second here, but we're going to have our live attenuated, we're going to have our killed or inactivated. We'll have fractional-based proteins. Our fractional-based vaccines will be broken up into several different types based on either toxoids or subunits. And then we'll look at recombinant varieties and then immune sera. So again, we'll kind of go through these more in detail as we go through the next couple slides here. And again, the immune sera really just providing passive immunity. So again, this is not actually going to generate immunity for the patient, but will allow for them to at least have some kind of passing resistance to something. Okay, so other components of the vaccine. So again, when you have a vaccine, it's not just the live bacteria or the virus itself, or it's not the killed version of it. There's a lot of either active or inactive ingredients, right? So we have things like preservatives, we have things like water that's in there, we have stabilizers, or maybe other antibiotics that are present. And this is where a lot of the controversy comes about. They think, hey, you're injecting all these chemicals, you're injecting all these carcinogens and all these terrible things. You're injecting dihydrogen monoxide into my child. You know what else that is? It's water, right? I like to call it hydroxylic acid too. That really scares some people. But But anyway, so the point is like there's a lot of other stuff that comes in these vaccines, and that's where a lot of the controversy comes about. Thimerosal, I mentioned, is a mercury-based preservative that was used in low doses for certain vaccines. We'll look at some of the links to autism there and what kind of the CDC says about that. And so again, patients could have allergic reactions to some of these products, right? So we'll look at allergies a little bit later, but you need to kind of look to see like, well, did they have a bad response to that particular vaccine? Is it because of the vaccine itself, or is it something that was co-formulated with? And those are questions you have to ask. And so again, different manufacturers will have different inactive ingredients. So you might try one from this company, they do really poorly with it. Otherwise, they can switch to another company and they do great. It just depends. So the first set we'll look at are going to be the live vaccines. So this is, and again, we're trying to closely mimic actually having the disease itself, right? So this is going to be the closest way we can do this. And so these are going to be attenuated or weakened versions of the virus or the bacteria, okay? And again, why do you want to make it weak or attenuate it? Yeah, you don't want to actually give them the disease. Like, I don't want to actually give you polio or something. I want to make sure I give you a weakened version of it that you can have a response to. However, it's not going to be, you actually get the true disease itself. Again, once they're there, they're going to be able to replicate, and this is why you get a much better response to it, because again, it tries to mimic an active infection without the patient actually getting sick. And so again, the immune response is very, very close to what the actual natural infection would have been. And typically you get a durable response, you have a better immune memory to this with fewer doses. And sometimes you may just get one-time dose and you're set, right? So it just depends on the vaccine itself. These tend to be more unstable. These are harder to store. They may have shorter, expiration dates, things like that, because they're a little bit more unstable, and they can interfere with circulating antibodies. So we're going to see, especially like little kids, like they don't get their MMR vaccine. MMR stands for what? Measles, mumps, and rubella, right? So they can't get that until 12 months because of the circulating maternal antibodies. We'll look at that in a little bit later on. But again, there could be issues with that. You can actually have severe reactions that are possible, and we already mentioned with immunocompromised patients, what can they be at risk for? Actually getting the disease, right? So they don't have a competent enough immune system to actually fight off the weakened form. They can actually still manifest the disease itself, right? So that's always a concern if you have, an immunocompromised patient, potentially a pregnant patient, things like that, right? Can pregnant patients get any vaccines? Absolutely, and they should, and we'll see why a little bit later on. But typically, live vaccines, you will kind of defer until either they're not pregnant or unless you have really some other good, compelling reason for it. So some examples. So MMR I mentioned is a good viral live vaccine, varicella, influenza, specifically the intranasal form. We'll talk about it a little bit later. Rotavirus, and then some of the bacterial ones, things like BCG. Now, do we recommend BCG over here? What is this for? Yeah, it's for tuberculosis, but typically used outside of the U.S., so not used here. And then oral typhoid would be another good example. So again, not used. Some of these are used very commonly. Some of these are used, especially on the viral side. We don't use a lot of the bacterial ones here routinely in the U.S. Maybe like some specific use cases. Anyway, then moving on to the killed or the inactivated forms of it. Again, these do not replicate, right? Because it's the killed off virus or the bacteria. And so they don't really replicate that same sort of kind of a natural immune response. So typically you're going to find, repeated dosing is going to definitely be necessary to get that good durable immune response. It can be kind of a temporary sort of humoral response you're getting initially. So again, generally 3 to 5 doses are going to be required, and after the second or third dose is when you start to get more of a protective effect. But initially, especially the first couple of months, you may not really be getting a whole lot of benefit out of that vaccine until later on. So again, it's one of those things where you kind of have delayed gratification from that standpoint. And then this is another case where antibody titers can diminish over time. So this is where you need like your booster shots. So you can think of anything you might need a booster for? Tdap. Yeah, like your Tdap or tetanus specifically, diphtheria. Anything else? Hepatitis B can be another big one, right? So you get your Hep B booster. So, for instance, like if you go to work in a hospital, they will usually test you for HB titers, and if your titers are too low, they'll go ahead and give you a booster, right? Because again, healthcare providers are a particular risk for infectious disease, right? Because we're going to be dealing with patients. But anyway, those boosters kind of help to activate those B cells, and they retain that immunologic memory for a longer period of time. They kind of reset it a little bit. So there's just some examples. You can have some that are going to be whole versions of the virus, the bacteria. So for instance, influenza. This actual form's not available here in the U.S. anymore. We have things like polio, rabies, we'll talk about a little bit later on. Bacterial ones we don't use too commonly. We'll have different varieties we'll use. And then you can actually get down to specific fractional versions. So again, these are just kind of subunits or pieces of the virus or the bacteria. So things like hepatitis B would be an example of this. Influenza is the one we use more commonly. HPV, which stands for... Yep, so we'll talk about that a little bit later. Why do we worry about HPV? Yeah, it can cause cervical cancer and warts, right? So we worry about that. And then we'll also look at the toxoid. So this is specifically against a product of the bacteria or virus, not necessarily the bacteria virus itself, right? So we'll talk about like tetanus toxoid or diphtheria toxoid. We'll talk about management for that. Anywho. So then looking at the polysaccharide vaccines, so the main one I think about when I think polysaccharide vaccines, I think like pneumococcal vaccines. And so basically the pure polysaccharide is, and again, what type of molecule is that? Just a sugar, right? So typically pretty small compared to something as more protein based. And so you may find, this is just a portion of like the external capsule of the bacteria. And these are typically kind of T cell independent sort of reactions. They don't really get as good of an immune response, especially for like smaller kids, like less than 2 years of age. And you really don't see the same kind of booster response you would normally get as opposed to if it was conjugated. And so that's why these conjugated vaccines that are here usually are kind of attaching it to a protein that makes it much more immunogenic, and it gets more T cells involved with that, so you get a much more durable response out of that. So for the pure polysaccharide, I mentioned pneumococcal, but also meningococcal, salmonella can be included with this one. The conjugated ones, though, and again, you can give this as young as 2 months of age and get a good response from those infants. Be like H flu type B, the HIB, pneumococcal, and then meningococcal as well. So you see different varieties availability. So again, it'll say like conjugated or polysaccharide protein conjugated. That'll be listed on the actual drug itself. And if you were to look up in Lexicomp, you'll see there's 2 different varieties. If you type in like pneumococcal, there'll be the regular polysaccharide and then the conjugated one, right? Okay. We have some recombinant vaccines. So this is actually where we don't actually take the virus itself, but we'll take a piece of it and try to insert that viral gene segment into usually yeast. I see yeast used most commonly. And then once that yeast can actually start to produce the viral proteins, we can modify that and use that to make some vaccines. So for instance, hepatitis B vaccine is one we'll use pretty commonly. And also the HPV vaccine, or Gardasil, is the most common brand name you're going to see for that. And there's actually some live attenuated recombinant varieties, and so intranasal flu is probably the most common one that we use. That is a live attenuated recombinant form. So we actually had like yeast cells produce that for us, rather than actually having to kind of cultivate the virus and have it replicate on its own. Okay. So those are the different varieties of vaccines. And again, we'll look at some specific examples a little bit later on. But the other thing to look at is the timing and the spacing of vaccines. So in general, as a general rule, all vaccines can be given at the same visit as other vaccines, right? So again, does that mean the kid's going to get everything from what they need from day 1 to year 18 at one time? They probably look like either they went to acupuncture studio or a porcupine or something like that. We don't do that, right? However, they can get multiple shots at the same time. That's totally fine. The question is like, what types of shots are they getting? Are they getting live attenuated, or are they getting one of the other varieties essentially? So as you can see, if you're giving 2 or more inactive, you can give them simultaneously, right? Or you can give them at any interval. So I can go and get an inactive today, and I can get another one 2 weeks from now, and they don't tend to interfere with one another. They don't tend to be any less immunogenic. They don't tend to kind of decrease the efficacy of any one or the other. Okay, that's fine. If you're given inactive vaccine and a live vaccine, those can be given together or at any time. Again, they don't kind of interfere with one another. The problem you run into is you have 2 or more live. If you don't give them together, you have to separate them out by 4 weeks. You find otherwise that when you kind of boost up the immune system for the first one, by the time you give the second live, if you give it too early, you don't really get a good response to that second one. So that's why we separate out by at least 4 weeks. Okay, and that's why when you see, excuse me, when you see kind of repeated doses of a vaccine, especially a live one, you're going to find that they are separated out by at least 4 weeks. You want to give your time, the immune system to kind of peak up and then kind of get back down to baseline before you re-challenge it again. That's going to lead to the most kind of durable responses, as we'll see. So again, looking at multi-dose vaccine series, I was kind of mentioning here, again, the minimal time, the minimum interval between doses should be at least 4 weeks. Typically, you're going to find much longer durations there. So again, 5 to 6 months in some cases between doses of vaccine series. And typically what they'll do is they'll put the longest interval between usually the second to last and the last dose between there. So maybe 5 to 6 months between those two. So you may get say like a month, day 0, and then a month 1, 2, and 3, and then you get it, say 6 months later. And that tends, they've done studies to show that this produces the best kind of antibody response when challenged with the virus or the bacteria. And so typically what you're going to find is that if you delay the dose, so say someone was on vacation and they were a month late in getting their vaccine, that's okay. You can delay it, and you're not going to run into any issues. That's within reason, right? You don't want them to take 10 years off between their last dose. They're not going to really have a good response to that. However, you don't want to do it too soon. That's the other big component there. You don't want to come in any sooner than what the actual recommendations are, because again, that will interfere with how good of a response you get. Does that make sense? So you can be late getting another dose, but you don't want to be too soon. Usually 4 weeks is that minimum. Okay. Now, if you have an immunosuppressed patient, not only do you have to worry about, especially with a live attenuated vaccine, of actually developing the disease, but if you're giving like an inactivated form or just like a subunit of the virus or the bacteria, you may find that with immunocompromised patients, they cannot mount a good response to it, so they may not actually get a good immune response at all, and may not actually develop any kind of real immunity to that. This is important if you're actually putting them on immunosuppressive therapy. Okay, so what are some examples of immunosuppressive therapy I might put a patient on? Yeah, so like biologics. So specifically when I say biologics, I'm referring to, DMARDs, right? So your anti-rheumatic drugs, absolutely. What else? Yeah, corticosteroids is the other big one, right? So corticosteroids, they're going to be on long-term corticosteroids. That tend to be immunosuppressive. That can limit how effective your vaccines are going to be. So in general, what they recommend is you either do, say, vaccinate 2 weeks before, or you do 3 months after, say, especially when you're doing something like radiation or chemotherapy, they're like really immunosuppressive. And again, if you can do that, it's going to be like to have kind of the best response to the vaccines. And we already kind of alluded to that when we talked about the biologics before. Now, if you were having to give antibodies, right, because again, you want to give vaccines and antibodies, typically you don't want to give them at the same time, because what would, if I gave, say, a live attenuated virus, and then I gave an antibody against it at the same time, what do you think would happen? Antibody would just inactivate the virus, and you wouldn't really get any good immune response, right? Similar to how maternal antibodies may make some vaccines ineffective early on if you give too soon. So what they actually recommend doing here is if you give the live vaccine, give them first, then you wait 2 weeks before giving the antibody. That will allow the vaccine to actually have some effect and actually generate some immunity. If it's less than 2 weeks, you may actually have to test for immunity, test for those titers there and see if you need to repeat the vaccination. And then the other flip side of that, if you give the antibody first, you have to wait at least 3 months or longer, because otherwise those antibodies will sit around, because those proteins, they last a decent period of time. They'll stick around and they'll inactivate that virus if you were to inject that vaccine. Make sense? So you can try to get the vaccine first, otherwise the antibodies are going to make it less effective. Okay, so looking at contraindications and precautions for these vaccines. So again, if you have an anaphylactic allergy to a component in the vaccine, you generally should not use that vaccine, right? So again, you don't want to cause an anaphylaxis. Typically, you don't want to treat through that. It's not really worth the trouble. Again, C here stands for contraindication, P is precaution, and V is vaccinate. Okay, if they have an encephalopathy, typically you don't want to administer at that point. Again, you want to kind of deal with any kind of like major medical issues first before vaccinating there. So one thing I recommend not vaccinating for. If they're pregnant, typically hold off of giving a live vaccine. That would be contraindicated. You can defer that until after the pregnancy. Otherwise, if they have an inactivated vaccine, you can go ahead and give that, right? So for instance, what do you think would be most commonly we would give to a pregnant patient? Flu, yeah, flu is going to be most common. What's another one? Pertussis is going to be the other big one, right? Because again, whooping cough is a big deal. Infants have a hard time with that, and there's a lot of mortality associated with that. So they actually have strong recommendations to get boosted up on your Tdap, get that acellular pertussis to prevent whooping cough. If they're immunosuppressed, typically no live vaccines. We've kind of already mentioned why that is. We don't cause disease, and they probably couldn't mount a good response to it anyway. And then they can go ahead and vaccinate for an inactivated virus. Again, they may not have a good response to it. They may need repeated dosing, but you can test for that with titers. If they have a severe illness, their immune system is already ramped up due to fighting off some other infection, probably have a precaution there. You may want to hold off until that's kind of subsided to some degree, and then before you vaccinate, but no clear contraindications to that. And then if they receive a recent blood product, so again, what might be in a recent blood product? Antibodies, right? So again, you worry about that inactivating. So if what you're getting from the donor pool had a vaccination against a particular disease, you may worry about that interacting. So again, a precaution, but if it's in inactivated form, you're fine to go ahead and vaccinate. Okay. Now, just some examples of things you might have anaphylactic allergies to that you would want to avoid specific ones. And I'm not going to have you memorize this list here, but just know that, again, none of these are actually related to the actual vaccine itself. These are all going to be inactivated or inactive components here, right? So, for instance, with egg allergy, you think of the flu, right? So if you have an egg allergy, especially with the intranasal variety, you can't utilize this. You have to use a recombinant form of the flu vaccine to get around that egg allergy. Gelatin, latex. What do you think neomycin and streptomycin are? They're antibiotics, right? So those are antibiotics we actually utilize to maintain some of the sterility within the vaccine itself. If you have an anaphylactic allergy, you would want to avoid these or use some other variety of it. I've ever seen anyone have a reaction cross-reactivity between the aspirin and the live attenuated flu vaccine, but it is listed as a contraindication there. So again, don't memorize this list, but look it up, right? Again, egg allergy with the flu is probably the most common thing I hear of as being a precaution. So we always ask, hey, do you have an egg allergy before they get the flu vaccine? But just make sure you look it up beforehand. Screen for any kind of allergies. Okay, a lot of people may have latex allergies that they don't necessarily realize, but latex is used in pretty much all of the manufacturing of these vaccines. So be very careful with that one. Okay, so what are the routes we typically give our vaccines by? Mostly intramuscular, right? There's some oral varieties that are available. So I think like rotavirus has an oral variety you give to kids when they're very young. Some may be given via subcutaneous routes. And again, very rarely you may do intranasal, like the live attenuated influenza, flu mist. Anyone ever received the flu mist? Yeah, they actually haven't recommended for the past couple of years now, and I'll talk about that in a second, but that is one way you could potentially administer that, get around that needle phobia that occurs for some patients. Typically, for you're dealing with infants and toddlers, I do recommend using kind of the upper thigh. Otherwise, for children and other adults, just use a deltoid. They really don't recommend using any kind of the gluteal tissue there. Again, kind of potential inadequate response that they've seen in some studies. So again, just use a deltoid for most patients. Always use the upper thigh for little kids. All right, so adverse reactions you can see with vaccines. Typically, most of them are local issues, like usually some pain, swelling, redness at the site of injection. Those are all totally common to see with that. You're going to see these more often with inactivated vaccines. I don't actually know why that is, but it just happens to be the case. They're typically usually pretty mild, self-limited. How could you treat that? Just Tylenol, NSAIDs, anything like it is totally fine. Like usually if I have to give my kids a vaccine, if they're getting a vaccine, I'll try to load them up with some Tylenol afterwards. Because again, I know they're going to be hurt and I know they're going to be in pain and be really fussy. Give them some Tylenol, try to head that off a little bit. Because also when you're trying to trigger that immune response, what's another common reaction? Systemically. Fever, right? So you can see fever. So giving an antipyretic like Tylenol is a good option as well. Ibuprofen could work additionally. So again, systemically though, you can see headache, fever, all that. Very non-specific. Again, very mild for the most part. You can just use typical over-the-counter sort of stuff for that. Now again, rarely may see allergy. By screening for those things we already mentioned in that last slide, you can try to help hopefully mitigate a lot of that. However, a lot of people might not know they have those allergies, especially little kids. Again, their first vaccine. So again, it may be something you can't necessarily avoid. But again, very rare you actually find allergic reactions, true anaphylactic allergies for most patients. Okay. So if you did have an adverse event, though, this is very important that we monitor for adverse events. And so vaccines have their own program. So this is what's called the Vaccine Adverse Event Reporting System, or the VAERS system. And it's actually done by the FDA. So that way, if we had like a new vaccine that came out, and all of a sudden we had a rash of, say, Guillain-Barré, that's one of the concerns you have with certain vaccines that started to occur, you can track that, you can monitor for that, and see, yes, okay, is it just a random occurrence, or is there maybe some a little bit more correlation there that needs further investigation? Obviously, what's kind of the worst case scenario you could do with a program like this for the actual vaccine? Take it off the market, right? So again, if it was seen as causing all these problems, you can just take it straight off the market. This is how we can monitor for that sort of thing and make sure we kind of mitigate any damage, or at least mitigate whatever damage is already done there. There's actually a National Vaccine Injury Compensation Program. So if people feel like they've actually been injured or harmed by vaccines, there's a way they can get some sort of recompense for that sort of thing. So again, there's other systems that are out there, and that we do monitor for these adverse effects to make sure we don't have any kind of big issues we're missing there. Okay, so who's seen stuff like this before? I'm sure maybe a site or two on Facebook may have posted a picture. Something like this, I might imagine. Right, so again, all these things that are listed on here is like neurotoxin, potassium chloride, neurotoxin. I guess, but I mean, like, we all have potassium in us already. Like, okay. There's some other thing on here, but basically those vaccines can cause narcolepsy, they can cause autism, paralysis, dystonia. Again, this is probably blown a little out of proportion if I had to guess. That's me being conservative. But again, you're going to run into patients who have these thoughts. They have these, again, places like Facebook tend to be a lot of echo chambers of positive confirmation bias, these sorts of things. They hear of anyone having an adverse effect, and they think, okay, well, that must be true. Everyone's going to have that adverse effect. One of the big things here, or at least it was a controversy for a while, was the concern of thimerosal, as I mentioned, has mercury in it, causing autism. Now, is mercury a neurotoxin? Absolutely. If you get too much mercury in various forms, it absolutely can cause neurotoxicity. Mercury is nothing fun to play with. However, it's very small amounts of mercury, and it all matters in the actual form of it and how it's being given. And so, for instance, like the CDC went through and they're looking at all the studies that they were able to find out there. They were actually showing that, hey, look, there does not appear to be any kind of consistent link between causing autism for patients who have these vaccines. And so they do these comparative studies. They do these cohort studies where they look to see, like, okay, who's got the vaccine, who doesn't, and they see, well, who develops autism, right? They don't see any major differences there, no statistically significant differences. You can't really draw that conclusion that occurs there. And in fact, there's some studies they were looking at, for instance, like Denmark and Sweden, they stopped using thimerosal altogether. And if these vaccines did cause autism, what do you think would happen when they took all the thimerosal out? You expect autism rates to go down. What do you think happened? It stayed exactly the same, right? So it's one of those things where, you know, you can try to utilize information like this. You can try to pull all the best information, say, well, listen, this is what we have. Here's all the studies that they've done. There does not appear to be a link here. Is that going to convince everybody by appealing to reason? Unfortunately, no, right? Especially if they're like, well, yeah, the government told you that. The CDC said that. Sometimes you just can't win with certain people. And again, no one's being forced to be vaccinated. There is no legal ramifications for not vaccinating. However, it is strongly recommended, obviously, right? So again, any questions on that, or anyone run into? I'm sure everyone's got a crazy aunt or uncle. We talked about like the tracking nano machines they put in the vaccines, so the government can track you everywhere you go. I was like, yeah, but you got your phone in your pocket. They're already tracking you. Google knows more about you than you know about yourself. Anyway, so looking at immunization schedules. So again, this is going to be one of the big things to do if you're dealing with pediatrics on any routine basis, is looking at their schedules. Here's a list of recommended vaccines that we'll typically get in the typical course of childhood. So anywhere from hepatitis B, rotavirus, pneumococcal, polio, influenza, everything in between. All these different things you can confer good resistance towards in these kids. Now, every year, a new schedule gets released in January by the CDC. So they publish this every year. And again, do you need to memorize this list? I don't recommend it. If you use it every single day, you're probably going to know it by heart, right? But I'm not going to make you memorize this for the test, okay? I will show you the picture, what it looks like. Who would like to memorize that? I mean, if there's a consensus, I can put it on the test. I don't hear anything, so I'm going to assume no, you would not like that. Now I'm a little negligent. I had the 2017 recommendations here. I actually looked when I was updating this, and I saw they're very similar to 2018, so I did not actually change the pictures. However, you can pull this up. Go to cdc.gov, look up child vaccine schedule, and you can find all this information there. Okay. Basically, it'll tell you specifically, okay, at birth, what are they supposed to get? Okay, they get Hep B at birth. Great. You know, most kids before they leave the hospital will get their Hep B shot. They're good to go. Then you have, at 1 month, they'll get their second dose of Hep B. And again, you'll just go through it. Okay, well, how old's the kid when they're coming back? You know, okay, this is the doses they're going to get, and they'll get all at one time. So for instance, like the 2-month visit, not very fun, right? Because they get all these vaccines all at the same time. Those kids are cranky. Very much. As they say, some kids get very sleepy after they get their vaccines. My kids did the exact opposite. They became little terrors afterwards. So your mileage may vary on that sort of thing. But anyway, so yeah, you'll follow up on this, and again, they will also have catch-up schedules, right? So again, if you have someone who maybe does not seek medical care for some period of time, you know, they don't come to their well checks for a while, they have means of catching up on this. And again, the main thing they're shooting for with that is making sure you're doing the appropriate minimum amount of time between doses. So for instance, if you're looking here for hepatitis B, they're giving you those minimum recommended doses or time between doses there. So between dose 1 to 2, they should get 4 weeks at least, right? You'll see nothing on here that's less than 4 weeks because you need time to allow that immune system to kick up, you get in high gear, and then kind of go back down to baseline before you re-challenge it. Okay, so again, their catch-up schedules are out there. You can look that stuff up. I'll be very handy. Again, if you use it every single day, you'll probably get pretty good with it, and you'll just kind of know what they're going to require, right? Now, I cannot say for Dr. Nicholson's class what she will want you to know about this stuff. I don't know. I don't take her class. However, my purpose is we're going to be more focusing on the concepts behind this, right? So little things like, you know, a patient comes in, you know, they just got their first hepatitis B shot, you know, say 3 weeks ago, and they're ready for their next dose. You know, is this appropriate or not? You know, things like that. You need to kind of infer like, okay, well, no, it's not. You need to come back in another week, right? Because you need to at least have 4 weeks in between these shots here, right? So little things like that. There's also an adult immunization schedule. So do you think this requires more or fewer vaccines? Typically a lot fewer, right? So again, They also will recommend certain things that all adults should get, and then they'll recommend certain things that certain patient populations, certain cohorts should receive. So, for instance, for all adults, they should probably be up to date on their tetanus status, right? MMR, varicella, and influenza. Influenza is going to be the most common one they're going to get. They should get that how often? Every year, right? Because again, it's going to update every single year. Look more at that in detail in a minute here. Certain things, for instance, as they get older, like they'll only recommend certain types of vaccines. So, for instance, the IM influenza is only going to be recommended for them, not the flu mist, as we'll see a little bit later. If they're 65 or older, they recommend getting a pneumococcal vaccine. And then they'll have a lot of specific recommendations based on disease states. So, for instance, if you have AIDS, you have certain recommendations. If you work with, say, in a biolab and you have you're working with certain strains of meningitis, you need to have a vaccination for that. So, some of that, what do you call it when you get vaccinated for something prior to an exposure? Pre-exposure prophylaxis, right? So again, if you have a high risk of, say, contracting rabies, you probably get pre-exposure prophylaxis to rabies. So that way, you're vaccinated, you're immunized against it before you get bit by, say, a rabid raccoon or something like that, right? It's like the way to say that. So those are things. And then if you were to get vaccinated, say, after you were exposed to it, you call that post-exposure prophylaxis. So again, that's kind of the terminology we use for some of this stuff. So some of these things will be kind of pre-exposure prophylaxis for high-risk individuals. Some of these things are going to be just recommended based on the disease state. So for instance, we have here like influenza, they just recommend 1 dose annually. So that's never going to change there. For here with like say TD and Tdap, what does that stand for? TD stands for tetanus and diphtheria. Good, what's Tdap? Acellular pertussis is what that is referring to. Notice here how some of these are some of these letters are capitalized. We'll talk about DTaP a little bit later on. That's a little bit different, but basically they'll say, okay, well, this one you should get every 10 years. You get a booster every 10 years because you don't keep a good durable or lifelong response. However, they recommend doing Tdap for the first dose, and then after that you only need to get TD, right? So that can be important. You would ask, hey, have you ever, when's the last time you got your tetanus booster? Say, oh, it was, say, 12 years ago. Most people, they're going to say what? I don't remember. If you don't know, then oftentimes you just say, well, I'm just going to go ahead and update it. So when do you think you need to worry about tetanus status for most patients? Like say they're presenting to the urgent care clinic or the ER. Like injuries, things like that, if they have like a laceration or bites, things like that, where you can have kind of foreign, well, we'll talk about that later, but basically whenever you have any kind of penetrating injury, typically you worry about tetanus status. Anywho. Things like MMR, varicella, herpes zoster, HPV. We'll talk about that a little bit later with Gardasil specifically. But again, some of these are only going to be recommended for additional medical conditions. So if you look at this next slide, I believe, or I'll look at that in a second. But looking at immunizations based on if you're pregnant, if you have HIV, if you have asplenia, if you have COPD, any of these things that can lead you to have some degree of immunocompromisation, they will make specific recommendations for you. Also include contraindications as well. So for instance, if you're dealing with someone, say who's immunocompromised, so say they're like on active chemotherapy, they're very immunocompromised, they would recommend against MMR, varicella, and herpes zoster. Okay, these are contraindicated, so that's good to know. Notice these are live vaccines. Notice it's also contraindicated for pregnancy, right? For diabetes, they would recommend again getting influenza. Get your, some of them will not be different than typical adult patients, but again, it's good to kind of look at your diabetic patient. What do you need? Kind of go down the list and see what they should be getting. Okay. Again, don't memorize this list. Just know you can find this stuff. The CDC is the place to go for it, and it's going to update every single year. So this is 2017, but it didn't really change too much between last year and this year. Okay, so looking at special populations, more specifically with infants, you're going to see that because of that passive immunity they get from mom due to the transfer of those maternal antibodies, mostly during the 3rd trimester and also with breastfeeding, this can actually inhibit that immune response to the live viruses. I can inject the live viruses, but mom's antibodies are going to inactivate it and won't be very effective. So that's why you don't want to give things like the MMR until 1 year. So by 12 months, they see that enough of the maternal antibodies have been degraded and they're gone, that you can get a good response to a live vaccine. So that's one recommendation for infants. Now, if you're dealing with premature infants, they get treated the same as regular term infants. So again, you're basing it off of postnatal age and not on gestational age. So that'd be one case where you don't change your dosing recommendations or a vaccine schedule based on how premature they were. Because again, if anything, who's more at risk for disease? Premature infants, right? So again, the more premature they are, the more likely they are to get some of these infections. As I mentioned, for pregnant women, typically the benefits for some of these outweigh the risk. I mentioned no live vaccines for them. You can defer those typically. However, they do recommend influenza every year, and especially if they're looking to become pregnant and it's going to be around flu season, like that's going to definitely be recommended. And then due to pertussis risk, they also recommend getting Tdap during that late second to third trimester. And in fact, they even recommend it in some cases for dads to get vaccinated as well, or any like kind of close caregiver. So like for instance, like my mother-in-law comes and watches my kids quite frequently. She got her Tdap updated. I got mine updated with my first daughter. But again, we were good for the second one because again, you only need those boosters how often? Like 10 years, yeah. So again, it was only 19 months between the two, so we were able to we didn't have to get revaccinated for that. But again, that pertussis risk is a big deal. Okay. And again, to mention, avoid those live vaccines. It's not due to any kind of clinical evidence we have, but it's a theoretical risk. Most of those, the benefits don't necessarily outweigh the risk. Just defer till after the pregnancy. All right, for immunocompromised patients, so either with congenital immunodeficiencies, leukemias, chemotherapy, they'll actually list certain doses of prednisone. So prednisone is one of the more common corticosteroids, but you can use some other kind of equivalent dose of other steroids, right? Some of them are going to be more potent, less potent, but typically, if you're on pretty consistent dosing of corticosteroids, what kind of patients may be requiring this? Getting like corticosteroids every single day. Like rheumatoid arthritis is probably the more common thing I think of. But if they're having to get that every single day, like typically you consider them to be immunocompromised. They put some caveats on that. So again, if it was like a topical corticosteroid, if it was an inhaled corticosteroid, intramuscular or intraarticular, those don't really count because again, those are going to be very locally acting. They don't see a lot of systemic effects. Only like really oral parenteral corticosteroids count here. Again, basically they should be avoiding live vaccines. If anything, they may not elicit a full response. Worst case scenario, they actually have the actual disease itself. Okay, for healthcare personnel, because again, we are a special at-risk patient population, especially the more direct patient care contact you have. So for instance, they're going to recommend all getting the flu vaccine every single year. And in fact, if you don't get the flu vaccine, what do most hospitals make you do? Gotta wear a mask, right? So again, they will have certain restrictions they'll put on like visitations and things like that. At least over our hospital, we do that, where you have to either have the vaccine, you'll have like a little badge that says I got vaccinated. It's really kind of weird because I was like walking around with a badge that just said I'm vaccinated, and it doesn't like say for what. So it's like could be anything. I don't know, typhoid fever. But no, that's for influenza, and so you had to wear that. Otherwise, they would make you wear a mask essentially, right? And that was again from a patient protection sort of standpoint. Hepatitis B, they also recommend being checked for. So again, you would check a titer. Otherwise, if you don't have enough titers, you get a booster. You may need the full course. It just depends on how your titer responses are. And then I mentioned Tdap. Tdap, TD booster every 10 years. Otherwise, you may need to get that Tdap for the first one, essentially. Let's see. Varicella, they will recommend if you have no proof of immunity or you have like no history of disease. So if you didn't get like chickenpox as a kid, you've never been vaccinated against it, they would recommend getting vaccinated for that. And again, they'll check on these things for a lot of hospitals when you go to work for them. MMR in certain cases, like if you're born later than 1957 and no evidence of immunity or prior vaccination, they would recommend getting that. And then meningococcal is really only for people who have contact with certain like microbiologists, like certain contact with strains in meningitis. Now again, like it's not to say that meningococcal disease is not a concern for healthcare workers. So for instance, if you get a kid who comes in or a person who comes in and has meningitis due to Neisseria, you do have to do post-exposure prophylaxis for people who had like direct contact. So for instance, we had a kid a couple months ago who everyone was in the room with the kid before we knew what it was, and he was just kind of breathing just kind of to air. A lot of people in the room had to get exposure prophylaxis for that. So they'll have different recommendations, but we're not high risk enough that we need to be routinely vaccinated against that. So again, just go by the guidelines. A lot of places will have these already kind of set up in place as part of like an onboarding procedure to make sure you're up to date. Okay, so just going over a few vaccines in depth. The first one we have here is going to be for HPV. Anyone know the name of the vaccine we use for HPV? Gardasil was one of the big ones there. I always thought it was so cool. It's like we have a cancer that we can actually prevent with a vaccine. Like it's kind of neat. Basically, there's lots of different types that are out there. There are certainly is where we get a lot of genital warts that can come about from this. The big high-risk ones that we're worried about causing like cervical cancer include things like 16, 18, 31, 45. We're going to see that vaccines don't have to be targeted against one particular strain of a virus. It can actually be targeted against multiples. And so this is a good example of one that has multiple targets that it'll be shooting for. There's some other low-risk types that are available there. This will be important when we're looking at what coverage the vaccine provides. And that's the other thing to note is that, listen, like you may get vaccinated against certain strains of HPV, but will that prevent you from ever getting HPV? No, there's other strains that are out there. We try to cover the most common ones, this kind of thing. So it's like, people is like, well, the flu vaccine is crap because I got the flu vaccine, then I got the flu. That's okay, right? We understand that we're not covering every single strain of flu ever made, because again, flu changes every single year. There's lots of variety there. However, you're covered against the most common ones, and again, we see good benefit from that when you look at the studies. So a lot of people have HPV. Does everyone that has HPV know about it? No, and it can also make you at risk for contracting other sexually transmitted diseases. Like HIV tends to be more commonly to contract if you have HPV, things like that. This is why it's so important to try to prevent that. But the other big thing was the cervical cancer risk, because you can actually prevent cervical cancer via certain types. So, for instance, 70% of cervical cancers in women were due to type 16 and 18. So, if you can target those two specifically, that's a lot of cervical cancer you can prevent potentially. Right, so I mentioned a lot of people are asymptomatic, so you could be passing it on to other people and not even know about it. And so the most common kind of manifestation would be usually the anogenital warts, or you can find other issues that can pop up from this. So certainly not just cervical cancer, but anal cancer, etc. So that's where we came up with the HPV vaccine, or Gardasil. So this actually got approved back in 2006. It was a quadrivalent vaccine, right? So again, quadrivalent just means targeting 4 strains, right? So we have 4 strains that are being covered here. So again, these are the highest risk ones for cervical cancer and the one causing genital warts. So again, does not prevent you from ever getting HPV, but it will prevent you from getting those 4 varieties of HPV. And so initially it was only approved for female patients, because again, that was really only got marketing for was for the cervical cancer risk from that standpoint. Nowadays, who do we vaccinate? We do males and females, right? So it really doesn't matter. Anyone can potentially get HPV. If we can prevent it, it's going to be great. And in fact, you'll find that we actually have an even better variety of it now that actually targets even more strains of that, which I'll show you in a second. But again, remember minimum intervals, no less than 4 weeks between doses. Here it's a 3-dose series where you do 4 weeks between the first 2 doses, and you do 12 weeks between the second and third. That way you give the time for the immune system to kind of really get back down to a good kind of low-lying state, and then you challenge it one more time, and you get a very good durable response for the lifetime for that patient. So the other one we have, there's a Cervarix one that was only targeted against HPV type 16 and 18. I don't think that gets used very frequently. Does anyone remember any kind of the controversy behind Gardasil when it came out? Not necessarily from that standpoint. It's like people who were like saying like, don't get vaccinated by this because you're going to be promoting people having sex, right? They're going to say, well, if you can't get one of these diseases, then you're more likely to go out there and have sex. That is not a valid argument, I would say. However, that was an argument some people made. So I think that is probably where the Cervarix came from. So, well, this one's only for the cervical cancer. So if you're giving it, it's only going to be to prevent cervical cancer. I don't know. The thing that we use nowadays, though, is Gardasil 9, and this actually presents as a nonavalent vaccine, so known as mean 9. It's actually covering a wider variety here. So again, these are the most common ones that we think cause disease in people. Covers all of those, and you're vaccinated. Again, not 100% protection against all strains of HPV, but just these 9 specific ones. So usually recommended at adolescents around 11 to 12 years of age. Again, we're not just females, but we will do male patients as well nowadays. And so typically you can start the series, can be started as early as 11 or 12, but usually around 13 to 26 is when you can actually get started if they've never been previously vaccinated. So you can start it a little bit later on. Usually 13 to 21 for male patients. And again, they will actually recommend for those that are more at risk for developing HPV and maybe more at risk for things like HIV, especially if they're immunocompromised. So if they have HIV, they actually extend out how late you can actually get that. Or men who have sex with men could be another case where, again, HIV transmission is easier if you have HPV. And since they're at high risk, that is one other group that they would extend out how late you can start the vaccination schedule for. And again, you should try to administer this before the onset of sexual activity, because if you already have one of these HPV strains, does this protect against it? No. So once you already got the disease, you're kind of too late at that point. So if you can start it before sexual activity, that's going to be good. But of course, I guess I won't recommend this for my little girls because they're never going to have sex until they're 30, so it won't be a really big problem, right? Anyway. So as I mentioned, no effect on existing disease or infection, but you can do it a little bit later. It's okay for females 26 of age or younger who are, if you have any kind of abnormal, Pap tests, genital warts. So again, it's these things where they may have one type of strain, you can still protect against the other one. So it still means that you can have some protection, just not against the strain they already have, essentially. Now, as far as cervical cancer screenings, if you get the HPV vaccines, I mean, you never have to get checked for cervical cancer ever again. No, so basically, you still need to get screened appropriately. You still recommend that you don't get like a get out of jail free card from the Pap smears for the rest of their life. They still need to get those routinely. So it's really good to educate women on that. Let's see. Okay, so moving on to influenza. So certainly influenza, how is that transferred usually or transmitted? Yeah, usually respiratory secretions, large particle droplets, airborne transmissions, why it's so contagious. And it's one of those things where people can be contagious far before they actually develop actual symptoms, which can be problematic. And then you have a lot of viral shedding associated with this, so it's very, very virulent. A lot of people are going to get this unless they're vaccinated, which again, you'll find that depending on the strains we're going to go with, you can have some that have very good years and you can have very bad years, right? Does anyone remember when the swine flu was big? Right, so swine flu came around. Like I remember, I was on rotations when that occurred, and I was in the pediatric intensive care unit. I saw it was the first time I ever saw someone go on ECMO before. Have I mentioned ECMO before? It's extracorporeal membrane oxygenation. It's basically where you put them on a bypass machine, where you kind of take care of the machine takes over the heart and lung feature for them. First patient I ever saw that developed that went on ECMO due to swine flu because, again, they just had no protection. It was a really nasty strain of the influenza virus. However, nowadays we actually will cover for an additional strain of that, as we'll see when we look at strains in a second here. But anyway, so again, very easy to try to vaccinate against. You may have good years where you have really good protection. Some years you're not really going to get very good protection. This is one of those years. It's kind of a bad one. I mean, if you look at the news, there's tons of cases of people dying from influenza, a lot of hospitalizations because, again, the vaccine was not perfect this year. Again, never is perfect, but it was less perfect than usual this time. So again, when does flu season really hit? Usually the winter months, right? So again, usually start out like your flu blitz programs in hospitals and things like around November time. Get them vaccinated because, again, we're kind of at the tail end of things right now. Flu season definitely starting to kind of wean off, but we're still certainly seeing several patients get diagnosed with this every single day. Now, we were going to recommend the flu vaccine for everyone who's 6 months of age or older, as long as they don't have any actual contraindications. So everyone should be receiving this yearly as long as they're 6 months and up. Okay. Again, I mentioned it gets formulated annually, so based on circulating patterns of flu, based on these epidemiologists and these microbiologists who are looking at this, they kind of determine what's the most likely cause for influenza that year. The 4 most likely strains. We used to only do 3, but after H1N1 kind of took a big hit, we added on an additional 4th strain. And so you'll find that usually you can, if you had a trivalent form, which again is only 3 strains, you cover for 2 strains of A and then 1 of B. Nowadays we will cover for 2 A's and 2 B's. There's still some trivalent forms out there, but in general, you get most of the people will get the quadrivalent form. Okay. So, for instance, for this year, and I pulled this off of the CDC website, the trivalent vaccines would cover for, and again, I'm not going to have you memorize this. I'm just showing you specifically, here's how they target for different types of strains. But here's one, the Michigan variety. I don't know if this is where they isolated it from. I'm not a virologist, so hard to say. One from Hong Kong, this one's from Brisbane. Does anyone know how to say this? Don't pronounce it. Just don't try. Anyway. However, so that quadrivalent form would actually contain an additional B strain. This is one that it would actually cover for here. So this is H1N1, so that's the strain that the swine flu was. This is one we really wanted to start covering for. And I believe it was this H3N2 strain. This is the one that was not really protecting like it should be this year around. This is why we're seeing so many flu cases, right? So again, either you'll have issues where the ones that we're covering for, we don't cover it for effectively, in which this happened this year, or you'll have strains that maybe were more predominant than what you expected and it wasn't ever covered for in the first place, right? So when swine flu came around, that was a year we didn't really cover for that variety of flu, and then when it became so predominant, that's what really kind of knocked us on our butts because we had no means to prevent it really, right? And again, do we have a really effective treatment for influenza? No, not really. We can only really treat it symptomatically. There are an antiviral that we can give. Anyone know the antiviral we use? Tamiflu or oseltamivir. It's not even a great drug. It can sometimes shorten duration of symptoms, but again, it's not awesome, and you have to give it very early, at least within the first 48 hours. Otherwise, you kind of lose a lot of efficacy. So again, if we can prevent it first, it's always going to be better for our patients. So anyway, so some of the varieties we have. So for instance, we have this inactivated form of the vaccine. So IIV is just inactivated influenza vaccine. So there's lots of different brand names you'll see out there, so don't try to memorize that, but just know this is the intramuscular variety, and this will be given for anyone that's greater than 6 months of age. Really, anyone can receive the intramuscular form. There's no kind of absolute contraindications besides allergy, right? Besides any kind of anaphylactic allergy. And so what you'll see is that usually most people will get how many doses of the flu vaccine in a year? Just one, generally just one. However, there are some cases where we may, for little kids less than 9 who are getting it for the first time, we'll actually give them 2 doses, and we'll give that 4 weeks apart between the 2 doses to kind of get them, and this will be along with their other vaccines, but to kind of get them get their immune system really kind of juiced up initially, and then they'll get 1 dose every year after that. There's also a recombinant form. This is good for patients who are allergic to eggs, because this actually lacks those egg proteins. So again, patient who has an anaphylactic allergy to eggs, they cannot receive this intramuscular injection. However, they can get the recombinant form. Okay, so if you RIV, that's what it stands for, recombinant influenza vaccine. And then there's the flu mist, which is going to be the intranasal form. It's actually interesting. I was looking this up, and again, this is a quadrivalent form. This is only recommended for healthy persons who are aged 2 to 49. So as soon as you hit 50, you can't even. This is not recommended for those patients anymore. This is good for patients who are like needle phobic and really wouldn't have gotten the vaccine otherwise. However, most people should just get an IM. I'm sure most of you have received several flu vaccines in your life. How bad does it hurt? It's not that bad. Some people are really scared of needles, though. However, what's interesting is that they still have the same 2-dose recommendation if it's their first time getting it. However, for the past 2 years, the CDC has actually recommended against using the flu mist. They find it's not really providing enough protection like the intramuscular variety does, and so they've only been recommending the intramuscular. So again, it changes from year to year. Next year they may say it's okay. However, right now it's not approved or not recommended to use the flu mist. Again, looking for allergies, egg allergies can be a problem here. They actually recommend not using aspirin in addition to this due to, actually I have no idea why they recommend that, but there's some potential risk for patients who are using concomitant aspirin. However, why don't you want to use aspirin in those kids anyway? They had the flu? Yeah, you were at Ray's syndrome, so we wouldn't want to do that anyway. Also, don't recommend it for pregnant women, because again, this is a live attenuated variety, right? The other version is the inactivated form, the intramuscular. The flu mist is going to be a live attenuated, so this is why we don't want to use it in pregnant women, immunosuppressed, anything like that. So again, not recommended currently for the 2017-18 flu season. Who knows what it'll be next year? All right, so are there any questions from what we covered yesterday? On a smattering of things. Some urology, did some Jerry, did some immunizations. No questions, no thoughts, concerns, quips, quibbles, quotes. Okay, moving on. You guys are probably too tired for exhaustive mental processes at this point. That's okay. I'll warm you up into it. Let's talk about rabies. You guys know something about rabies already, right? Mongoose, yes. Are mongoose the plural? Mongai? I read some mongai one time. Did you see the picture of the mongoose someone posted? I did see that someone posted a picture of a mongoose. Okay. Does anyone know what mongoose are good at killing? Snakes, yeah. Ricky Tikki Tavi is what I always thought about as a kid. A lot of people are familiar with that piece of children's literature, but that and like Bunnicula. Any Bunnicula fans? Was a vampire rabbit? Very strange. Kids' cartoons are very odd back then. Anyway, a lot of acid involved in some of that. Anyway, so rabies. So again, this is a neurotropic RNA virus. Why is this so bad? Why do we care about rabies? Yeah, and so like when you see it already occurring, when you see symptoms, guess what? Too late at that point. It is very unlikely that you'll have people actually survive this if they are manifesting symptoms. There's a couple of case reports that are very interesting. You can read, they have these different protocols they have tried before, where basically they will try to completely put the patient basically under general anesthesia. They'll try to cool the patient. They'll do all these really kind of heroic efforts, and there's only been a few that have actually survived it. But very, very deadly if it's actually showing symptoms. And again, there's that latent period. It's kind of the issue there, and it can be variable, as we'll see, depending on kind of where it happens. Now, is rabies such a big deal in the U.S.? Not as much, right? So in other countries, especially more developing countries, maybe have less access to things like vaccines and the immune globulin. You're going to see there's some bigger issues there. Anyone know like a big spread of animals outside of the U.S.? They're not like such a big deal here. We're not pets necessarily, but like rabid dogs. You see a lot more like dogs that are kind of wild dogs that are out there. Versus here in the U.S., most of the dogs around here are usually domesticated, usually have vaccines. Usually not going to be exposed to a lot of rabies. But anyway, and interestingly enough, found everywhere in the U.S. except for Hawaii. So again, they're a little bit protected there, being kind of off in the middle of the ocean. Anywho, so again, this is almost always through a bite. However, there are rare cases where you can have things like aerosolization, you can have transplantation. So this is one of those things you do screen for prior to donating organs and things like that. And I mentioned dogs account for quite a bit of it in developing countries. However, here in the U.S., we worry mostly about what? Raccoons are a big one, otherwise known as trash pandas, right? That's a good name for it. Anything else? Bats are the other big one, right? So bats, especially like with bats, are bat bites usually pretty vicious? Not really, right? They're very like kind of these like needle-like things. So like that's why they recommend if you wake up in a room and you see a bat, 1, panic, and then 2, get tested for rabies, right? Because that's one of those things where you just don't know, and sometimes you may have no markings whatsoever if you'd actually been bit. So that's one of those things. Anyone ever see a movie, The Great Outdoors, with John Candy and Dan Aykroyd? Please go watch that movie. It is very funny, but there's a funny bat scene where they're trying to get it out. Anyway, but skunks, don't play with skunks. It's just bad advice in general. Foxes, things like that. So again, those are the most common ones. And so one of the big things you'll have to do from, say, like an urgent care or say like from a emergency room sort of standpoint is like kind of doing this risk stratification, trying to figure out what is the likelihood this person actually might have been exposed to rabies after an animal bite. You'll do some other prophylaxis as well, based on the type of animal it was. So for instance, what's a good antibiotic to use for, say, like a dog bite? Augmentin is really good, right? Because it helps to cover anaerobes. And again, Augmentin is amoxicillin plus clavulanate or clavulanic acid, and that's good because it adds on that extra anaerobic coverage, which there's a lot of anaerobes in the mouth and whatnot. Even though they say dogs' mouths are cleaner than humans, but guess what? They still have anaerobes there, just like we do. But usually you can get away with a lot of Augmentin for most bites. However, if you have odd animal bites, and again, being in Florida or a little bit of kind of wild country, we had one case where we had actually an alligator bite. Alligators being, in the water, they have a different kind of biome of bacteria growing in their mouths, and so we have to do different coverage. I remember what we covered with it for that kid. I think it was like Levaquin and something else we ended up using for coverage there. Anywho, despite that tangent, we're talking about rabies here, right? So someone's like, yeah, we are. You forgot. You went off on tangents. Anyway, so basically what you end up seeing is that the virus will be introduced, say, into a wound, usually peripheral wounds that are occurring in there, usually on the hands. And think like little kids who are trying to reach down and touch an animal, touch a panda, or a trash panda, I should say, a raccoon. And then what basically will happen is the virus will actually have to travel up that nerve and to eventually get to the CNS. And so, again, depending on where the bite is, it can take different periods of time. So, for instance, if you got bit in the foot, that takes a longer time than it would be if it was in the hand. So, little things to think about there as far as how long before you actually would start to manifest symptoms. And they can be secreted here for a rabid animal, into the salivary glands. That's where you see a lot of introduction of the virus there. Of course, the factors here are going to involve things like, the infecting variant, the inoculum size of how much actual virus was introduced into the area, that site innervation, as I mentioned, and then the kind of the host immunity. So who do you think might actually have kind of innate immunity or have developed immunity to rabies due to vaccination? Say we're doing like pre-exposure prophylaxis. Like animal control, right? So again, if you're going to be exposed to those sources of rabies potentially, like you probably want to get protection for it beforehand. So you'd have people who are in animal control, if they have that history, you can ask them that and see if they've been previously immunized for rabies, right? That can change your management for these patients pretty significantly. So, very interesting sort of symptoms that can happen here. So like the encephalitic symptoms that can happen. Patients develop hydrophobia. What is that? Yeah, kind of scared of water. Aerophobia. Of air or like wind, so it's kind of interesting as you watch some of these videos, like really kind of late stage rabies, they'll like kind of do like little puffs of air against the patient, and they're just like, they're really kind of freaked out by it. It's kind of sad for the patient because obviously, if they're that symptomatic, they're not going to be living for very long. However, very interesting from a kind of clinical standpoint. There's some paralytic symptoms associated with this as well. And again, it takes time for this to occur. And by the time symptoms are already showing up, it's going to be no good for your patient unless you get very, very lucky. So we can see for that incubation period, 1 to 3 months average time. However, in some cases, it could be up to a year in very kind of slow moving sort of cases. But bites that are closer to the brain, so think about the face, places like that, it's going to incubate a little bit faster. Typically, the lower extremities, as I mentioned, is going to be the slowest time to onset there. So obviously, what's the best thing to do once you've been bitten by an animal? Wound care, right? So you want to wash off the wound. That's usually going to be the best thing immediately. You can get soap and water. It's funny, whenever I talk about snake bites, I always say, like, the best thing you can do for as far as first aid goes, because even if you hear snake bites, a lot of people want to try to like suck out the venom, or they want to try to excise the wound, things like that. I always say the best thing you can do is get a set of car keys. Right, because it's implying that you would drive yourself to the ER, get checked out, and someone's like, "What do you do with the car keys? Do you like rub the wound?" I was like, "No, nope. You drive yourself." Anyway, but good wound care, soap and water is gonna be really important here. If you can use something like a virucidal agent, so like povidone iodine can be very effective at killing off the virus there. It ends up reducing your likelihood by like 90%. So it's very, very effective trying to prevent infection there. And then obviously antibiotics, as I mentioned, good stuff for anaerobic coverage. So if you can get something like amoxicillin, clavulanic acid, that would be good. As a backup, what could you use if a patient had like a true amoxicillin allergy, penicillin allergy? What's other good things for anaerobes? Clindamycin would be a good option. Again, clindamycin also covers what? Gram-positives, right? So it covers gram-positives and anaerobes. And again, what's on the skin usually? Mostly gram-positive, right? So again, think about your coverage. And again, if you look at like the Stanford Guide or something, you'll see those recommendations with your primary is, which is usually augmentin, and then a backup if they have a true allergy. So, and then we'll look at tetanus prophylaxis a little bit later. So again, how often do we update our tetanus? Every 10 years. What do you do the first time you do a booster? You do Tdap the first time. So if you go back and look at those charts, you'll see we do Tdap usually the first time, or if they have like, we'll talk about it, tetanus a little bit later on, but if they've already had that one time, then you just give them the TD. So again, you don't need the acellular pertussis more than that first time. So, all right. So anyway, going to the actual, because rabies is such a serious condition, if it actually does occur, if you need to give it, this is where we can do the rabies immune globulin. So again, the rabies immune globulin is going to do what for us? And directly target that virus and try to inactivate it immediately, right? So this is where we have the human-derived immune globulin. So basically, you would have human patients who have been immunized against rabies, and then you can donate that plasma. It will harvest that, and then we can utilize that drug essentially. Usual dose is like 20 units per kilo. Again, I'm not going to ask you doses specifically, but just for your reference. And this is what our preferred variety is here in the U.S. And so we have a couple of varieties available. We have like Hyperrab SD. We have this Imogam rabies. There was an equine-derived immune globulin that we had for a period of time, but again, what's the problem with using foreign proteins? Anaphylaxis, right? So again, equine proteins tend to be much more antigenic than you would see with human proteins. Not to say you couldn't have a reaction to the human immune globulin. However, equine is much, much more likely to cause reactions there. And it goes, so the nice thing here is immediate neutralization. And how would we administer that? So you can do it intramuscular, but the more beneficial thing to do, because we mentioned that it has to travel up the nerve to actually get to the CNS. Well, what if we just gave it right around where the actual virus would have been inoculated, right? So we can do things like infiltrate it around the site. The question is, like, how much can you actually infiltrate into the area? So for instance, with the finger, do you have a whole lot of space where you can inject fluids? Not really, right? So you can do as much as you can around the site, and then you can use the rest of it into the deltoid, right? So you give as much as you can around the site, infiltrate it around, and then use it as an intramuscular injection for the rest of it. So that's what we do most commonly for those kind of high-risk patients. Now, as far as the vaccine goes, typically you're going to have, antibody production within 7 to 10 days or so, and this will persist for several years. So again, you have pretty good coverage from this. We have a couple of different varieties here. We have this human diploid cell vaccine. We have a purified chick embryo. Again, just depends on where you're working, what they have available. So again, you don't have to really worry so much about which agent to use. Both are going to be fine in this case. And then typically when you're dealing with these patients, we will go ahead and give the immune globulin and the vaccine at the same time. Typically, if you're going to do intramuscular, you want to split those up and use 2 different sites for those, so the vaccine in one and the immune globulin in the other. But you're not going to be giving them the full course essentially, so you're going to give them the first dose, and then who follows up with them afterwards. So the health department is going to be the next person to kind of take the reins of that. So again, it's really important to have good reporting mechanisms in place to make sure that the health department is aware that there's a patient who's received the first dose of the vaccine, and then they will follow up to make sure they actually finish out the rest of the course. They get that from the health department directly. So that is typically what the process is. You may only be there for the first dose for them in most cases. So anyway, so again, we will, there's different dosing recommendations if you're doing pre versus post-exposure prophylaxis. For most of your patients you're going to run into, it's most likely going to be what? Usually post-exposure prophylaxis. Usually someone coming in saying, hey, I got bit by a raccoon, I got bit by whatever. Now in some cases they say, hey, I got bit by Sparky, my little dog. How do you kind of risk stratify to see if I need to really treat for rabies? Yeah, so that's one of the things we like to ask. Like, okay, well, do you have any information if the dog was vaccinated? They can provide that information, and you feel reasonably sure that that's accurate. Then yeah, that's totally great. Well, what if you didn't have access to the dog?
Could you look at like reports from the area to see if there have been reports?
You can look to see how frequent it is, and again, dogs we know are kind of low risk anyway. But it's one of those things where, if it sounded high risk, if it sounded like the animal's, giving any symptoms, right? If they was like, yeah, he's foaming at the mouth, he's acting crazy, he's totally unprovoked, that would lead you to think more like rabies, right? So again, these are all kind of little pieces of information. That's why it can be so difficult to decide kind of should we treat or should we not treat. Again, look at the animal it is, look at the kind of the situation of the bite. If you have access to the animal, we can always quarantine. That's always going to be one thing we can do to prevent having to treat the patient if you can. Because again, you don't have to give these medications unless you really have a good need for it. But most frequently, it's going to be like an animal that was, a neighbor's dog or something like that, and usually you can get information about it having vaccines up to date, and it's not manifesting any symptoms. It's very, very low risk, very unlikely to cause rabies in those cases. So generally, you don't have to really do much besides wound care, tetanus prophylaxis if needed, and antibiotics, right? Because usually, for the most part, we end up treating more. Covering for the antibiotics standpoint as prophylaxis rather than doing the rabies, probably 9 times out of 10 in most cases. So again, for looking at the difference in dosing here, if you're doing post-exposure prophylaxis, the primary thing you'd be doing is using basically starting at day 0, so they get that either in the urgent care or get it in the ER, and you do it on day 7, 21, 28, so the health department will be following up with them to make sure they get those subsequent doses there. Again, the booster, may get a booster if they need be, just one-time dose it would be fine to kind of reinvigorate that immune response there. So again, looking at the algorithm, you can kind of get a good sense for, okay, well, how high risk does my patient sound? So for instance, did a rabies exposure potentially occur? Question you're going to be asking, did the animal with fur bite the patient? So again, if it was a lizard, probably unlikely to have rabies, right? So this is more of a kind of a mammal sort of thing here. I guess the hairless cats could also do it as well, but so take it with a grain of salt. Did the patient have an open wound, broken skin, mucous membrane contact, anything like this? If no, obviously they don't need any kind of post-exposure prophylaxis. Did the patient have direct contact with a bat, such as that a bite or scratch cannot be ruled out? That's where they wake up in the room and they have the bat like hanging out in the corner. Again, that would be one of those things where because the bites are not going to be super obvious, you may not even feel it. That'd be one of those cases where you want to go ahead and usually do a post-exposure prophylaxis just to be on the safe side. And again, you have to invite vampire bats into your home anyway, so just don't do that in the first place, and you're set, right? All right. So then you're looking at how high risk was the animal. Was it something like a bat, a raccoon? Is it available to test? How often do you think that's the case? Generally unlikely, right? I know some people actually keep raccoons as pets. They obviously would get vaccinated. I do not recommend that. This lady, she would come in with scratches all over herself because raccoons, I guess their claws are basically like their fingers, right? So you can't really declaw them, and so it looked miserable. She's like, but I love my raccoons. They're cute, but I'm not gonna hang out with your raccoon ever. Maybe if you don't have it available to test, you have to kind of go to the worst case scenario, right? Those are high risk animals. But in a lot of cases, if it's a dog, a cat, a ferret, don't hang out with people with ferrets. But in general, if you had to have exposure to that, look at the animal. Is it healthy? Is it available for quarantine? Or does it have history? Does it have papers saying that it was vaccinated? That's a very low risk. Typically, you don't need to do the PEP, right? So again, you'll just kind of go through that algorithm every time. You don't want to leave it up to just chance. Go through the algorithm, see how high risk they are, and see if you really need to start PEP or not. Okay. So moving on to tetanus. So this is typically, and this is a vaccine that's not really targeted towards the specific virus itself, but it's actually targeted against, or the bacteria, I should say, but it's actually targeting an exotoxin here. So tetanus, what happens with tetanus? Who developed tetanus? Yeah, you get this muscle spasms. You basically have this kind of very, very tight muscles that happen here. A lot of it is due to this prevention's blocking of the release of inhibitory neurotransmitters. So actually glycine and GABA get inhibited. So you'd have this kind of unopposed sort of stimulation for muscular contractions, so they get very tight. You know, kind of also look, you know, any other like kind of drug-induced conditions that look kind of like that? Maybe like antipsychotics.
PCP?
Not really PCP. Remember we talked about, yeah, so like dyskinesia kind of manifests like that, but I'm thinking like neuroleptic malignant syndrome. If you remember, we talked about that. Get that lead pipe rigidity, that kind of looks kind of similar. But again, look at the history, look at what was most likely to have caused that. You can see a lot of muscle spasms here. Certainly have some dysregulation of the autonomic nervous system being affected by this. You can have aspiration pneumonia secondary to this, so lots of, you know, kind of a bad player. But where do people typically pick up tetanus from? Yeah, usually the environment, right? So it's going to be like on the ground. It's going to be, you know, on metal that you've maybe punctured yourself with or something like that. You know, so oftentimes like we think about like trauma patients, right? So they're coming into the trauma center, like, you know, we think about them, you know, motorcycle accidents being, you know, scraped along the ground. That could be a big source for tetanus. You know, so think about the history, think where that stuff could be coming from. Now, what we will oftentimes give here is tetanus toxoids. This is the actual vaccine that we would administer. This is where you find it in like the Tdap or in the TD. And so this toxoid is going to be targeted directly against that exotoxin itself. Again, good for providing, you know, coverage for 10 years or so. And usually it's going to be in that part of that wound care management along with diphtheria. So usually that TD is where you're going to see that. Now, there's also there's Tdap, which I mentioned has the tetanus, diphtheria, and what was the last one? Acellular pertussis, that's for the whooping cough. What's the difference between Tdap and DTaP? No, so actually, either Tdap or TD is usually the booster you're going to use. The thing here is DTaP, and Dr. Nicholson will probably cover this. This is going to be the pediatric version. So they changed the dose of the diphtheria. That's why they have a big D and a little t here instead of big T, little d. That gets very confusing. A lot of people are like, which one do I use? If they're under 7, typically you're going to use DTaP. If they're over 7, you can use Tdap. I don't know a good way to memorize that, but you just get used to it if you work with kids frequently.
Only the D requires pediatric dosing?
So you're just giving a bigger dose of the diphtheria, right, rather than the tetanus being kind of the predominant thing there. So that's just the way it's formulated. I don't know of any specific reason why it is that way. I guess to get a good immunologic response with the diphtheria, you just have to give a bigger dose to kids versus like an older patient.
In general, with vaccines, do children require larger doses just because of, like how you were saying, on some of the dosing, like their volume of distribution and things like that of nature? Or
No, volume distribution doesn't play so much a role into it. In some cases, that patients need smaller patients need smaller doses, right? So, for instance, if you're looking at the flu vaccine, or actually, I think like Hep B is a good one, a good example. Hep B, there's like a pediatric version, and then there's the adult version, right? And usually the dose for peds is smaller. So it will just depend on. And again, this is just a formulation thing. The dose, the actual volume you're administering is the same regardless. You know, it's still like a 1 ml administration. It's just the components. They just kind of bumped up the diphtheria dose there. So, again, I don't know if there's any specific purpose for that. If anyone knows, you can inform me.
Is there a certain amount of tetanus shots you can give, or like boosters within 10 years? Like, you know, if you have trauma patients coming in, oh, I don't know if I had one before, and then keep giving them. Is there a certain amount that you can give?
That's a good question. Yeah, oftentimes people will say, because again, if you ask me, when's the last time I had my tetanus booster, I only know because I had a kid within the past 2 years, right? So I only know that because I was trying to cover for that whooping cough there. However, most people, does anyone know when they got their last tetanus booster? Some people do not know. They could not remember. Right, so in a lot of those cases, you would just go ahead and give it, right? So you kind of go the worst case scenario, say let's go ahead and give it. It's one of those cases where you guys are way better up on your vaccine history than I am. But usually there's no issue with giving it more often than not. So if anything, you know, there's really no downsides to it, really. There's no like kind of immunizing effect you get to it. Like there's no I've never seen like anaphylaxis to it. No negative downsides to it. So again, if you don't know, just go ahead and give it. Or it'd be nice if you had history of like you actually administered it in your system and you have history of that. Like you can at least look it up and find that. But in a lot of cases you don't have that. Okay, so then we also have the tetanus immune globulin, and so this would be a good use case for patients who are unvaccinated, who have a kind of a more serious wound, and they're more likely to actually manifest tetanus. And so again, you think most patients, they probably immunized or probably not immunized against tetanus? Most people are, right? So most people do have the history of getting a tetanus booster, or at least having some tetanus series when they were a kid. However, especially being in the PEDS, there's been plenty of cases where they'll come in, they'll have some sort of wound, laceration, anything like that, and parents will say, "Oh, I've actually never vaccinated them against anything." In which case, you try to give them a stern, like, you should probably vaccinate your kids, and they're like, nah. And then so you have to have that conversation, okay, well, should we start the tetanus now? Are they high risk? Do we need to give the immune globulin? So this is another case where you actually have to go through an algorithm to kind of how high risk are they going to be here. So again, if it's a clean kind of minor wound, like, hey, it's a, it was a relatively clean, kitchen knife they cut themselves with, and they have no history of vaccination, they probably don't need the immune globulin, right? But however, you would want to go ahead and probably start them up on their tetanus series, at least with kids. And again, if they had an unknown when the last time their booster was, go ahead and give the tetanus diphtheria at that point, right? On the other hand, though, if it was kind of a very kind of nasty wound, it was something they picked up, like, from the ground or exposure to like dirt and things like that, again, that would be high risk enough. We would consider, okay, let's just go ahead and give the tetanus immune globulin and then go ahead and give them the vaccine as well. So it's one of those cases where we don't use the tetanus immune globulin too often, but it's good to know when you need to use it because, again, this high risk patient try to be safe than sorry in a lot of cases. Right? So that's it for kind of the vaccines kind of in depth. Again, I could go over every single one of them, but we'd be here till like next week. And again, a lot of the stuff you're going to look up, a lot of the stuff you're going to just be following the charts and kind of seeing, okay, what's the most up-to-date vaccine schedule I have here? Look at your patient, look at the disease states, things like that, and you kind of figure out what's going to be good to administer for them. Anyway, other things we can use from an immunologic standpoint is we actually have immune globulin that we can administer to our patients. So this is actually going to be IgG that is derived from donated plasma. And so again, it will be again from human sources. So can you see that providing a problem for any maybe specific cohorts of patients? Yeah, so religious patients, so not just any religious patient, but like things like Jehovah's Witnesses, you think of, they do not want to receive blood products from other people. This can be a problem with that, right? And again, you don't think like immune globulin, like you don't necessarily think it's like from a human source, but however, this is certainly, we don't really have a good way to synthetically manufacture that. So this is from other people. Again, it's been treated, so very unlikely to see any kind of communicable diseases being transferred there. But being that it's from a wide pool of people, you have a lot of wide variety of antibodies that are coming in. So, you can confer resistance against several different types of pathogens. And again, is this going to be long-lasting sort of protection? No, because as soon as that immune globulin is gone, once it has a decent half-life, once it's gone, at that point, and the patient has no other immunity at that point. Half-life anywhere between 18 to 32 days, so they don't have to receive it too frequently, but it's good to know that, after that month period or so, like, you're going to start to see waning levels at that point. We use this for a wide variety of different conditions. So, for instance, if they have a primary immune deficiency, we might be replacing this kind of on an ongoing basis for them. Otherwise, you get very immunocompromised, very likely to come with an infection. We use it for different disease states like idiopathic thrombocytopenic purpura. Use that occasionally to try to help get their platelet levels back up. Kawasaki's disease. We use this very frequently for off-label uses for a lot of like autoimmune conditions. The only problem with this drug is it's very, very expensive. So you want to make sure you're not just kind of using it just for anything. But this is one of those cases where you have a lot of disease states where you're kind of at your wits' end. You're like, I have no idea what else to use. Let's try immune globulin and see if that helps. Sometimes it does, sometimes it doesn't. The only thing to consider, though, is because you're injecting other people's proteins into somebody, you do run the risk of having some reaction to that. So again, you can kind of do pre-treatment. You can do things like Benadryl. You can do things like steroids to try to pre-treat to prevent a reaction. Some people are going to have anaphylaxis, but it was pretty rare for the most part. But again, you're going to see a lot of kind of rate-related chills, nausea and vomiting related to these infusions here. So typically what you will do is you'll kind of have this titrating administration where basically, and this is only an IV medication, obviously, cannot do this orally, but you basically start out, let's say, like start 10 mLs an hour, see how the patient responds to it, and then if they do well for a few minutes, then you can kind of bump up to 25 mLs an hour, and then do 50, and then do 100. And so you do those kind of things to make sure the patient's not going to have any kind of infusion-related reactions, in which case you could slow it down if you needed to at that point. So again, very expensive. So again, $200 for a gram of the drug, and usual doses maybe anywhere between 0.5 to 1 gram per kilogram. So you can start to see how this cost can go up pretty significantly very quickly. Lots of different brands that are available here. So you have things like GammaGuard, Gamunex, Octagam. Usually that has some sort of immune globulin kind of GAM sort of name to it, so you can we'll kind of recognize that. There's lots of ones that are out there. However, it's good to know that based on kind of the preparation process, if a patient has a reaction to one, doesn't mean they'll have a reaction to every other product. So certainly we'll have patients who are maybe allergic to GammaGuard, we'll give them Gamunex and they do just fine. So one thing to note there. And again, I mentioned there's religious concerns with certain groups. All right, and the last thing we'll talk about is going to be our Rho-D immunoglobulin. So anyone know what we use this for? What patients might receive it? Yeah, pregnant patients. You're right. So what do we use this for? All right, so we try to prevent hemolytic disease of the newborn. Why might they have a hemolytic disease? Right, so if mom is Rh negative and the baby is positive, mom can start to generate antibodies against the baby that will start to circulate. And again, this, mom has to be exposed to the fetal blood, which doesn't happen super frequently, but it starts to happen more later on in the pregnancy if there's any case where there's maybe any kind of transfer there, and you will see that mom will start to generate antibodies against that D antigen. It will start to transfer over into the baby because again we know that immune globulins can transfer over to the placenta very relatively easily, and then we'll start to generate a reaction against there. You'll start to see opsonization of those red blood cells. You start to see hemolysis. That can be bad for the newborn, right? We typically want newborns to have blood in general. So this is one of the cases where actually we'll give it to Rh negative female patients. So for instance, I'm Rh positive, my wife is Rh negative. So for both pregnancies, she actually got RhoGAM for that, right? So that way it kind of prevents her from starting to generate any antibodies, because we will give this immune globulin that will kind of bind up any of those fetal blood cells that might be Rh positive, right? They're circulating around in her bloodstream. So again, you need to know the mom's Rh status prior. She needs to, you don't want to give it if she's already positive, because again, she would not generate any antibodies against that antigen at that point, or if she already has anti-Rho antibodies. So if she's already developed those antibodies, there's other things you can do for the fetus kind of later on, which I'm not going to get into, but just know if she already has the antibodies, giving the immune globulin doesn't really do any good at that point. Anyone know when you would give it? Yeah, usually 28 weeks. Again, that's when you're going to start to see a higher risk of having those fetal blood cells from kind of entering the mom's bloodstream. It's when you're more likely to get closer to labor. And then typically you won't need to give it again until, anyone know what time you have to give it again? It's like after 40 weeks and like 3 days or something like that. So once you're kind of kind of full term, you may have to give it again. Typically, a lot of patients only end up getting the one dose in most cases. There's some other uses we have for it. We use it sometimes for idiopathic thrombocytopenic purpura. In some patients, they respond well to that. Again, the mechanism I'm not going to go into, but you may see some other off-label uses for RhoGAM, but the most common thing you would use it for would be for pregnant women. So, any questions on the immunizations? I feel pretty okay with that. Again, I'm not going to ask you specifically on the schedule. Okay, a 2-month-old kid comes in, what vaccine should they get? I'm not going to ask that, but it'll be more kind of conceptually based. Might be more on, might go into more detail on specific vaccines, ones we talked about more in detail. So those are kind of things to kind of key in on. All right.